Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by independent educational grants from Otsuka America Pharmaceutical Incorporated and Lundbeck Incorporated.
Hello, I'm Dr. Stephen Stoner, Clinical Professor and Associate Dean for Student Affairs at the University of Missouri, Kansas City School of Pharmacy. I would like to welcome you to this program titled Exploring the Pathophysiology Basis of Post-Traumatic Stress Disorder. Today we are going to cover the following learning objectives. We hope to first increase your knowledge regarding the potential neurobiological mechanisms of post-traumatic stress disorder. We're also going to work to increase your knowledge regarding the different mechanism of action of different emergent therapies for the treatment of post-traumatic stress disorder. And then lastly, we do hope to instill a greater confidence in your ability to summarize how our understanding of the pathophysiology informs the mechanism of action of therapies studied for the management of post-traumatic stress disorder. Regarding the epidemiology of PTSD, the global lifetime prevalence of PTSD is somewhere in the neighborhood between 4 to 10%. That number will vary depending upon different studies that have looked at prevalence, but you can expect about 4 to 10% of the population globally to experience PTSD. Now, PTSD is one of the most common mental health conditions in the United States. Now, there is one misperception that most people have, and that is that there's a higher incidence of PTSD amongst the military population. And in reality, the number of individuals suffering from PTSD, 80% or greater, actually are within the general population. Now, amongst the U.S. population, about 13 million Americans experience PTSD in any given year. And this equates to somewhere between 7 to 8 out of every 100 people will experience PTSD at some point in time in their lifetime. The lifetime prevalence of PTSD in females is about 13%, whereas it's about 6% in men. Now, the median age for the onset of symptoms of PTSD is considered to be right around 23, with a pretty equal distribution with regards to ethnicity between Black, white, Hispanic, and Asian. So we're looking at the DSM-5 TR diagnostic criteria for PTSD. We have to have that index event. So that's criteria A. And then you're going to look at additional criteria B, C, D, and E. So let's start here because there's 4 symptom clusters that we're looking to identify symptoms in once we've identified that index trauma event. And the first one is re-experiencing symptoms, or what we call intrusion. We need to see at least one or more symptoms that fall in the intrusion or re-experiencing criteria. It can be recurrent or involuntary, intrusive, distressing memories of the event. It can be recurring dreams. It could be something termed as flashbacks. So you can see an intense, prolonged psychological level of distress with both external and internal cues within the patient. In addition, criteria C are avoidance symptoms. So you need to identify one or more symptoms that would fall in or under avoidance. This can include efforts to avoid distressing memories, thoughts, or feelings. It can also include efforts to avoid external reminders of the index episode or other distressing events. And the next is category D, negative alterations in cognition and mood, sometimes referred to as numbing symptoms. So this is criteria D. And this can be found in symptoms where the individual can't remember the event. They have persistent or exaggerated bad feelings, maybe distorted cognition, negative emotional reactions, withdrawn, lack of interest, feeling detached or estranged from others. And then there's really this persistent inability to experience positive emotion. And so any of those can be considered a negative alteration in cognition or mood that would fall under this numbing category. And then lastly, we also need to have at least two symptoms of what we call hyperarousal, or an alteration in arousal and reactivity. And this can really take the shape in many different forms, but it's an irritable behavior. It's angry outbursts that the individual displays. Maybe it's a degree of recklessness in their behavior, self-destructive, hypervigilant. Maybe it can be as simple as an exaggerated startle response. They can't concentrate, or maybe they don't sleep. And so again, we bring all this together. So when we look at the diagnosis of PTSD, according to the DSM-5 TR, we have the index episode, one or more symptoms of re-experiencing, one or more symptoms of avoidance, two or more negative or numbing alterations in cognition and mood, and then two or more symptoms of hyperarousal. But typically, symptoms have to have a duration of at least a month, and then we will typically see symptoms present within the first 3 months of the index episode. It's also imperative, in order to make the diagnosis, that there is clinically significant distress or functional impairment. And then obviously symptoms cannot be attributed to another mental or physical condition. It's really important, again, to identify that index episode. And the index episode can actually help inform the level of severity and help predict what the odds are of eventually developing symptoms of PTSD. So when thinking about this, if the index trauma is sexual relationship violence, the odds ratio is around 5.6, increasing the likelihood of developing PTSD. Child abuse would fall right behind that, somewhere between 2.5 to 4.9 in terms of an odds ratio, in terms of the trauma type that is likely to predict other events that are associated significantly with developing PTSD, or life-threatening illness or injury, interpersonal violence, combat, war zone exposure, and traumatic brain injury. So all of these trauma types can be predictive of developing symptoms of PTSD. When we break it down further and look at the different types of trauma, we can see that the average risk of developing PTSD after a traumatic exposure is really variable. Let's take a look at the pathophysiology of PTSD, and specifically, we're going to look at emotional dysregulation and fear response as a result of abnormalities found within the amygdala. Now, when we think about PTSD, there are fluctuating responses between emotional response. And you can see emotional undermodulation, and you can also see emotional overmodulation. So when we are thinking about emotional undermodulation, this would be where there is a heightened emotional and autonomic experience. So the individual has a heightened response with re-experiencing episodes, feeling fear, feeling anger, guilt, or shame. And so there's diminished control, or this heightened emotional and autonomic response that causes. Now, this is thought to actually be the result of hypoactivity in the prefrontal cortex and in hyperactivity in the amygdala. So what occurs when the individual responds to trauma, they're exposed to trauma. If we see hypoactivity in both the prefrontal cortex, in the hippocampus, and increased activity in the amygdala, we see this heightened response due to emotional undermodulation. And so patients with PTSD may react with feelings of intense arousal and intrusion. Now, on the flip side, when we talk about emotional overmodulation, we're really thinking about the suppression of the emotional reaction. So we go from emotional undermodulation to emotional overmodulation. So in overmodulation, we see hypoactivity both in the striatum and the amygdala, but an increase in activity or hyperactivity in the prefrontal cortex. So when we see this, there's an increased control of the emotional response or the emotional reaction, and that you see emotional attachment uh, differentiate where the person they depersonalize, they experience derealization, they have this numbing effect or analgesic effect, and essentially maybe non-responsive, non-reactionary, referred to also as this emotional detachment. This hypoactive state of the amygdala and the striatum disrupts that reward seeking behaviors that we can see and will result in a negative mood and have a negative impact on cognition. So we know that the amygdala plays a central role in fear response. And we process fear in two ways. We either process it via the fear extinction pathway, or we process fear via the fear conditioning pathway. Now, in order to kind of break this down, let's start with fear extinction. The hippocampus helps us to process content and regulate fear. It's an off switch, if you will, for learned behaviors. The fear extinction alleviates what is considered a learned behavior and the absence of a negative outcome after a fearful event. So, also known as fear extinction. A good example is if you have a fear of snakes. So, seeing a snake in your yard while you're gardening versus seeing a snake in a glass aquarium, it's different. You are exposed to something that maybe scares you or invokes fear, but you can extinguish that fear when you can look at it in the context of the snake that's in the aquarium is not a threat to me. Now, when we look at fear conditioning, the sensory cortex and the thalamus activate the fear conditioning pathway. And think about fear conditioning more as a long-term response to fear. So it's memory and responses to fearful or aversive stimuli. And so that is fear conditioning. So dysfunction of the fear response in PTSD, again, we're focusing on fear extinction and fear conditioning. So there is an imbalance in activity between fear extinction and fear conditioning. So the fear extinction pathway can be inhibited due to a failure really from top-down inhibition by the prefrontal cortex. And there's prefrontal cortex and hippocampal dysfunction. That's going to disrupt the fear extinction pathway, and the individual may not be able to or will not be able to extinguish that fear, creating a heightened or abnormal response to something fearful or exposure to something fearful. Now, on the fear conditioning side, what happens is this pathway can be enhanced when there is an elevated noradrenergic tone and really increased sensory input. So the thought here is that with serotonin regulation, there is a reduction in serotonin activity globally. Abnormalities or reductions in serotonin along the sensory cortex and thalamus can result in um, this abnormal fear response as it relates to fear conditioning. You're starting to see, you're starting to think well, wait a minute, if there's a deficit of serotonin, how does that play into the different medications that are utilized to treat PTSD? Taking the next step and breaking it down from the amygdala to actually looking at the monoamine neurotransmitter activity and its role or their role in regulating responses to fear. So putting everything in context. So if we look at dopamine, dopamine as it relates to the pathophysiology of PTSD is going to be most commonly associated with the prefrontal cortex and the striatum. Now, next, let's take a look at norepinephrine. And norepinephrine is really going to be predominant in the amygdala and the prefrontal cortex. So in the amygdala, it's going to be more commonly linked with serotonin. And so there's some crosstalk here between the different monoamine systems. Serotonin is predominantly going to be found in the hippocampus and the amygdala. Now, when we break it down and think about PTSD, norepinephrine is associated with PTSD, hyperactivity or hyperarousal, intrusion. And this, we think, results from elevated levels of norepinephrine in these regions. Serotonin, we think of reduced activity or deficits in serotonin. And this contributes to symptoms consistent with mood, stress, and other abnormal reactions as a result of lower serotonin. And then lastly, when we think about dopamine dysregulation, we associate this again with avoidance, a lack of reward. So if there's dysregulation, there is anhedonia, lack of pleasure, kind of an emotional numbing, or even avoidance. So again, when we're thinking about PTSD, we're specifically looking in the regions of the amygdala, hippocampus, prefrontal cortex, and the striatum. And norepinephrine, serotonin, and dopamine all play a part in the symptomatology of symptoms associated with PTSD. When we look further into the level of monoamine dysfunction and fear conditioning and fear extinction pathway. So we know that when we look at fear extinction, high levels of norepinephrine can actually impair the prefrontal cortex functionality through the activation of alpha 1 adrenoreceptors. So the executive control of emotion can be impaired as a result of these elevated norepinephrine levels in the prefrontal cortex. Additionally, low serotonin levels can impair the hippocampus's control of fear processing. So again, context. So normally, again, the hippocampus uses this contextual information to guide the expression and response to fear. And then lastly, with regards to fear extinction and looking at the monoamines, you got to look at dopamine. And dopamine dysfunction in the prefrontal cortex and the striatum can again enhance the processing of aversive stimuli and disrupt that reward processing. So again, you would see negative responses, lack of reward, lack of response, anhedonia. It can lead to avoidant behavior. Now, when we look at the fear conditioning side of the response, high norepinephrine levels and low serotonin levels really can drive the activation of the fear conditioning pathway. And low serotonin levels can actually lead to increased norepinephrine release. And so norepinephrine increases in the amygdala to cause disruptions and its ability to condition the response to fear. So increased noradrenergic activity can increase the ability of the sensory experiences to be triggered. And this then can result clinically as hyperarousal, re-experiencing of the event, and increase the levels of fear. Lastly, we need to think about receptor dynamics within the amygdala. And We're going to be thinking about norepinephrine and serotonin receptors because, again, they are critical in addition to dopamine of modulating amygdala activity and its role in fear extinction and fear conditioning. Now, it's important to note that when we look at the receptor sites within the amygdala, glutamatergic neurons in the amygdala actually express alongside alpha 1 adrenal receptors, 5-HT1A receptors, and 5-HT2A receptors. Now, postsynaptically, alpha 1 adrenal receptors are excitotoxic or excitatory. Serotonin 1A is located both pre and postsynaptic and is generally associated with suppression of activity or having anti-anxiety calming effects, so decreasing fear behavior. Serotonin 2A is postsynaptic and is associated with excitatory responses. And then actually outside of the amygdala and in the prefrontal cortex, dopamine signaling may directly lead to avoidant behavior in response to abnormal processing of fear. So when we take a look at the receptor dynamics in the amygdala, we need to specifically look at the impact of norepinephrine and serotonin receptors, but also address dopamine dysfunction in that discussion. So when we look at the amygdala and we look within the amygdala and look at specifically the neuronal level with receptor activity, we need to understand that pyramidal glutamatergic neurons in the amygdala express alpha 1 adrenal receptors, serotonin 1A, and serotonin 2A receptors alongside one another. Now, we know that alpha 1 adrenal receptors are located postsynaptically and are considered to be excitatory or excitotoxic. Serotonin 1A is actually located both pre and post, and it is associated with inhibition. Serotonin 2A is located postsynaptically, and its stimulation is associated with greater excitability. Now, outside of the amygdala and inside the prefrontal cortex, dopamine signaling can directly lead to avoidant behavior in response to the abnormal processing of fear, like we've discussed before. So, again, norepinephrine, serotonin, and dopamine all play a role in fear response, and disruptions will result in an abnormal fear response. Summarizing, we know that PTSD is in fact a very dynamic disorder and involves fluctuations between contrasting forms of emotional dysregulation. So again, talking about fear extinction and fear conditioning. PTSD involves the imbalance between both fear extinction and fear conditioning. And again, we specifically focused on the pathways within the amygdala. A dysfunction of the monoamine neurotransmitter systems, and specifically norepinephrine and serotonin, but also dopamine, can disrupt brain activity involved in normal emotional regulation and fear response. And then lastly, norepinephrine system hyperactivity combined with deficits or reductions in serotonin can increase these fear responses or abnormal responses to being exposed to fearful events. Let's now take a look at the treatment recommendations for the treatment of PTSD. Now, there are a number of different guideline recommendations and suggestions for what to be implemented in practice. But by and large, the majority of the guidelines are going to suggest that CBT or cognitive behavioral therapy and in different forms is the first line psychological treatment for PTSD. Now, from a pharmacologic perspective, SSRIs and SNRIs are considered first line treatment options. When looking at specific pharmacologic treatment options, the majority of guidelines feel very strongly for sertraline and paroxetine. Additionally, a number of guidelines also have fluoxetine uh, among the SSRIs of choice. So we're looking really at your treatments of choice from a medication standpoint: sertraline, paroxetine, fluoxetine, and then the SNRI, venlafaxine. So 3 SSRIs and 1 SNRI in the majority of the guidelines are going to be your pharmacologic treatment first options. Now, there's additional concurrent levels, of symptoms that may require additional treatment in terms of these comorbid conditions. As with the treatment of depression and using SSRIs and SNRIs, the side effect presentation is really, frankly, the same. So we would expect the similar GI type symptomatology. And it's important to remember, too, that when changing these medications, you do need to instill some sort of a taper off, with the exception of fluoxetine, in order to avoid any kind of discontinuation or withdrawal symptoms associated with SSRIs and SNRIs. Another category of medication that I just want to make a mention of, and that is benzodiazepines. And the majority of the literature, and I think the majority of us from a clinical perspective, would really argue that benzodiazepines are not an effective treatment for PTSD or the prevention of PTSD symptoms, and largely would say that the risks of using benzodiazepines actually can worsen the outcome. So there's an increased risk. There's the potential risk of a negative outcome far outweighs the potential for a positive outcome. And this could be because the benzodiazepines actually worsen the severity of the PTSD symptoms. And also then we know that in some cases, benzos can actually worsen aggression. And certainly there's the potential for abuse associated with benzodiazepine use. Another thing to consider in the treatment of PTSD is that polypharmacy is not an uncommon event. And it doesn't mean that it's all bad, but it does require a thorough evaluation of the treatments. And so if you look at PTSD treatment, just shy of 50% of patients are able to be managed on monotherapy. But beyond that, you will see a fair number of patients treated with either 2 or 3 additional therapies. And while sometimes that may be indicated, I would encourage you to make sure that you are thinking about dose optimization, thinking about drug interactions and negative consequences of adverse events. And then also, again, just really emphasizing the deprescribing or not utilizing benzodiazepines in the treatment of patients with PTSD. As I mentioned earlier, when we think about just the wealth of data that exists for the treatment of PTSD, far and away, the most evidence exists for SSRIs and SNRIs. And there are more favorable reports associated with sertraline, paroxetine, venlafaxine, and then I mentioned fluoxetine. Certainly still more, I would say, more favorable outcomes than negative, but re-review of some of the older fluoxetine studies maybe suggests it wasn't as effective as once thought. But again, still considered an appropriate treatment. Additionally, individual therapies with second generation antipsychotics, while there's data out there, there's really nothing strongly supporting the use of second generation antipsychotics, and in some cases, recommending against its utilization. For instance, risperidone has not been particularly effective in PTSD, and the results with quetiapine and olanzapine are somewhat mixed. So looking at new and emerging therapies, it's interesting to note that there really have been no new FDA-approved treatments for the treatment of PTSD in the last 2 decades. But recently, there has been some movement with new agents or even a combination of 2 existing therapies for the treatment of PTSD. The first is MDMA, and MDMA has been studied, and some initial clinical trials suggested benefit towards the treatment of PTSD. And again, MDMA has activity at dopamine 1, dopamine 2, beta adrenergic alpha 2, and serotonin, different serotonin receptors. So it involves activity at all of the players that you think about with regards to activity in the amygdala. However, some scrutiny has recently come with the evaluation by the FDA of the data set, and some concerns raised by the FDA led to the non-approval of MDMA for the treatment of PTSD. Now, on the flip side, 2 existing therapies, brexpiprazole and sertraline, are being looked at in combination. Now, obviously, sertraline being an SSRI, combined with brexpiprazole, which is unique in its mechanism as a second-generation antipsychotic, but it has partial agonist activities at serotonin 1A and D2 receptors, as well as having antagonistic activity at serotonin 2A receptors and alpha 1 B and 2C. So more to come on these 2 particular agents, but really the combination of brexpiprazole and sertraline is really probably the furthest along at this point in time moving forward. Now, we are going to take a look at some recent work that has been done with the combination of brexpiprazole and sertraline, and there are 3 relatively recent randomized controlled trials. These were double-blind, active controlled trials, 2 of which, Study 61 and Study 71, which were flexibly dosed, and Study 72, which was a fixed dose study. In these studies, brexpiprazole was combined with sertraline, or sertraline was combined with placebo. Now, these were 12-week studies with the primary efficacy endpoint being 10 weeks with the reductions in CAPS-5. Statistical significance was identified with brexpiprazole and sertraline compared to sertraline alone at week 10 in trial 061 or 61 and trial 071 or 71. And you will note that in trial 71, statistical significance was also noted at weeks 6, 10, as I mentioned, but then also week 12. And that was also replicated in study 61. But again, the primary endpoint was at week 10, and there was statistically significant improvement in global PTSD symptoms across really all 4 clusters, including re-experiencing avoidance, the negative symptoms, as well as hyperarousal. Now, there is one study, which is Study 72. Study 72 was, again, the fixed dose trial, so a little bit different trial design. But at week 10, there was no statistically significant separation between the combined treatment of brexpiprazole and sertraline versus sertraline alone with placebo. Now, what you will note, though, is that there was a similar response as to what was seen in studies 61 and 71, but there was a higher sertraline placebo response rate, which resulted in the combination of brexpiprazole and sertraline not separating in this particular study. But again, it did in studies 61 and study 71. Lastly, I just wanted to make mention of MDMA. MDMA was studied into phase 3 and received a breakthrough designation in 2017, but the new drug application was rejected in August of 2024. And you can see here placebo plus therapy versus MDMA assisted therapy responses. The bottom line, or the orangish red line, being associated with what the MDMA response was. And you do see separation from the placebo group that was receiving therapy. However, in the FDA's review, there were some questions raised regarding study design and how individuals were identified and enrolled into the study. And there was a good portion of patients that had actually used MDMA, and they felt that with their experiences with MDMA, it would be difficult to ensure that they were truly blinded to active treatment. So there were a lot of questions raised. And then there was a general sense that the therapy that was being used in addition to the MDMA was not really well defined. And so this was rejected in August of 2024. So in closing, we just would wrap up with saying that most of the PTSD guidelines are going to recommend both psychological and pharmacological treatment. Again, cognitive behavioral therapy being the preferred psychological treatment, with pharmacologic therapies currently existing of SSRIs and SNRIs as being your first line treatment option. We do know that psychotherapy can be limited in clinical practice because of limited access to resources, and it's not going to be uncommon that you'll see combinations of both pharmacotherapy and psychotherapy used. But again, we still need more data on the global effectiveness of using both together. So while no new drugs have been approved for PTSD treatment over the last 2 decades, there are SSRIs and SNRIs which are approved for the treatment of PTSD. Again, reminding you that polypharmacy is pretty common. While, again, not all polypharmacy is necessarily negative or bad, I do encourage you to critically evaluate the existing treatments, avoiding unnecessary polypharmacy, monitoring for drug interactions, and then also, again, making sure that dose optimization is occurring. And that concludes today's session and the update on treatment guidelines, preferred treatment strategies, the pathophysiology, and where we exist in terms of new developments coming forward for the treatment of PTSD. Thank you for participating in this activity. You will find useful tools and resources located on the right-hand side of this page.